I'm hoping that my small contribution today will in some way help change perceptions, even change your values and therefore your priorities when responding to the uniqueness of each person with intellectual disability you come into contact with within your field of work. This is my perspective, part of my story, my history as a parent of 3 children. 2 born with intellectual disability without known cause. As a wife, carer, founder and provider of numerous disability services, employer of many specialist disability support workers and coordinator of hundreds of community volunteers, I'm an advocate and dedicated change agent for people disadvantaged by handicapping conditions. I live disability daily. I work alongside and share in their lives. My pleasant son, Laurie, can immediately put the medical professional at ease. He's seen as a person first by extending his hand to shake yours, as he courteously says, "My name is Laurie. Have you been busy?" The person immediately warms to him, seeing him as a young man who presents with intellectual disability but has need of your special help. I also know he may suddenly change and become extremely anxious, terrified if faced with hospitalisation. Fear of the unknown, change of familiar routines, people in gowns, and the Doctor Who machines everywhere. Laurie's very sociable. He's 6'4" tall. He has a very large head, 66 centimetres. As a youngster, he was very hyperactive and a compulsive eater. He uses repetitive nonsense questions such as, "Will the scissors cut my shoe?" as many as 10 times until he's interrupted. And repetitive behaviours such as putting his sock on and off, and shaking it. Varicose veins appeared in teenage years, putting compression stockings on dead weight, long, heavy legs every day on a teenager, now young man, is no fun. He has had lifelong nocturnal epilepsy, and the associated risks of this condition are life-threatening. His tonic-clonic seizures often resulted in injury where he would be thrown out of bed, hitting walls, furniture and floors with force. He presently uses a monitored convulsion bed alarm. Having first-hand knowledge of SUDEP, sudden unexpected deaths in epilepsy, when following a seizure during sleep a few years ago, he suffered cardiac arrest. The bed alarm saved his life. My fear is that any morning we may go to wake him and find him dead. Laurie requires a meal management plan due to his abnormally small airway and the ever-present risk of choking. He suffers anxiety when out, which causes often and endless need to urinate, in and out of toilets. He's had pilonidal sinuses surgery, surgery for hemorrhoids, dental surgery, many, and has a perpetual obsession with cleanliness following bowel movements. His love is music, karaoke in fact. He loves performing, and he's a fantastic 10-pin bowler. He is training with support in hospitality and within the Aurora cottage industry. In contrast, it was sheer torture living with my second daughter, Virginia. She has autistic tendencies with many associated challenges. Hers was a difficult, excruciatingly long birth due to a very large head. Basically, the only interest the quizzical doctors had in her until she was about 9 years old was measuring her head. The majority of medical personnel assumed hydrocephaly, wrongly. She cried, she screamed constantly, night and day from day one, until about 2.5 years old. She hardly slept. and she was in and out of hospital due to being a continuously sick baby. They say she was born with a cold and ongoing high temperatures, respiratory tract infections, and she did cry incessantly. At this stage, she was not improving, was very behind in her milestones. Virginia was given ECT at roughly 2.5 years old. I wonder still, did they think that she was born with depression? Around the same time, bone marrow was taken from her without anaesthetic or sedation. I remember the doctor was unexpected and agitated when arriving in the ward, saying to the nursing staff he didn't have time to wait, and condescendingly suggested I pop out and have a cup of tea, then started to grope my little girl roughly. I felt uneasy and watched from a distance while 5 staff held her down. I still can hear her screams, often at night, when I close my eyes. The obviously concerned and deeply affected nursing staff approached me later to tell me they had reported the doctor, that this should never have been done to my daughter. This was one of the few times I felt any empathy or encouragement. You see, I was still battling with questions about why my beautiful daughter was different. There had been no diagnosis until she was almost 3 years old. If what I know now, I knew then. As a family, we virtually didn't go out. It was a nightmare. Just going out our front door, going out in the car. She appeared in terror at any change until things reverted to the norm. Virginia was large and overweight and didn't walk until close to 4.5 years old. It was quite exhausting carrying her everywhere. And her relentless screaming meltdowns caused much discomfort to her father and her older sister. Earaches to constant ear infections to hearing disorder, then grommets inserted, 2 broken arms from clumsiness. She had an eating disorder, insatiable hunger, where we had no alternative than to place locks on our fridges and cupboards. Hair loss in her teenage years, problems with menstruation, which she unexpectedly commenced at 10 years old. Her refusal to wear a pad and discarding them in full public view, causing deep embarrassment over the years, particularly to her older sister, non-disabled sister Angelique, who found living with these types of socially unacceptable incidents traumatic. Especially during her teen years, the years of college study, combined with extreme stress at home and the ever-present danger that knowledge of her home life could destroy her prospects of being accepted by her peers, because she played out an incognito life. She lived a lie alongside her teenage school friends, and to this day, this creates many guilty emotions still for both of us. Remembering that we've lived through a still quite recent history where the community view was that retarded children are inferior. And having a retarded sister and a brother, too, was very difficult for her to cope with. Virginia's volatile emotional outbursts continued well into her teen years, and although exhausted, I was persistent to find a reason. And her complex emotional condition was eventually linked to the diagnosis of a pituitary brain tumour, which requires ongoing monitoring still. She was also diagnosed with depression and commenced treatment for this mental disorder. Unfortunately, she also developed primary lymphedema, which makes walking painful and difficult. It's a little-known condition with congestion, obstruction of the lymphatic system in the whole body, which is non-curable. And it involves manual lymphatic drainage therapy daily, massage and bandaging, and wearing compression stockings due to the extreme swelling of the legs and feet, causing also warty folds on malformed toes and the dreaded cellulitis, which has resulted in a number of hospitalisations. She now takes a daily antibiotic. She went through a period where some community-based support staff refused to help with her personal care due to no one having experience or knowledge about lymphedema, and the lifting of her heavy legs to essentially dry in between the overlapping folds on each toe, or put her stockings on each morning following her shower, posed a risk of injury to their backs. No one had considered my back over all those caring years. There have been encouraging experiences over the last few years. We are thankful that eventually she has regular, knowledgeable GPs that provide her with sensitive, individualised care with a genuine interest in maintaining her health and well-being. Especially now she has added arthritis with bone spurs that require regular cortisone for pain. They have supported her, they've supported us through a period of emotional upheaval that confronted our family when Virginia met Shane through Aurora Day Support Services. And even though we did all we could to come between them, they wanted to be together, and for the past few years have happily shared their lives in their own home. My husband and I and Angelique now support them both as a couple. They really adore one another, and she, of course, is totally dependent 24 hours daily. CBS deal with her personal care daily, and he enjoys just fussing over her. Within my work on a daily basis, I'm aware of the ongoing vulnerability, exploitation, assumptions, mistreatment, lack of adequate support provided by our health and related systems towards adults with intellectual disability. Aurora is registered as an NDIS specialist provider. The majority of our clients are in the older age bracket and will not enter the scheme until 2019. Our values and our beliefs influence the way we live and work, the way we think, the way we talk and act, our very being. I've seen many die after a shortened, lesser quality of life existence, and am aware of many unanswered questions and probable failures in our woefully inadequate health system. At the risk of sounding negative, but I really do want to be positive, not all adults with intellectual disability are living a happy, adequate lifestyle, that is, with good and caring parents, or in supported residentials, free from the spectrum of abuse. Many live in lonely, inadequate circumstances, leading sedentary lifestyles, in squalid conditions with poor hygiene, both personal and environmental. They have poor oral health, limited literacy or budgeting skills, no cooking skills, no laundry skills, overweight, and yes, the person may be dirty, smelly, have bad breath, have incontinence issues, may be loud and demanding and confused, sleeping still in their clothes, don't like to touch water, have toenails that are so long they curl over the toes and under the foot. My experience of this is extensive. Others may present as capable, higher functioning, yet may not be able to do up shoelaces, buttons, or blow their nose, let alone cut their nails or put in eye drops. They tend to be undereducated, untrained, unemployed, poor, and therefore marginalised and vulnerable. They find it difficult to act for themselves, often don't have strong advocates, Many of their parents are uneducated and illiterate. Some require 24-hour support, yet to the other extreme, represent the people who are most likely to be in prison, homeless, or on the fringes of society. I'm sure you have experienced professional feelings of powerlessness when dealing with the unfamiliarity of this broad spectrum of patients. You're expected to know they have intellectual disability and immediately adjust your thoughts and actions accordingly. Let your care values kick in. See the person. It would be easy to become distracted and wrongly attribute the symptoms to the disability. We don't want failures or delay in diagnosis and treatment. Presenting to admission at hospital can be stressful, even traumatic, for people with intellectual disability carers and the nursing staff. A lack of knowledge, limited experience, misplaced assumptions or judgments, prejudice, ignorance and communication difficulties leads to discomfort and a lack of confidence with added anxiety if hospital staff are faced with challenging behaviours and unfamiliarity with this broad spectrum of patients. This could impede effective assessment of a person's capacity. You may unknowingly discriminate by denying a procedure or a treatment for reasons such as, well, I didn't want to upset him further, therefore becoming barriers to good health care. For example, there is the possibility of grave consequences if people can't communicate with hospital staff effectively. How can someone with poor communication let medical staff know that they suffer from chronic constipation? Communication difficulties can lead to inaccuracies and underlying advice given about management of this person, their history, or the reporting of symptoms. Doctors need to know how to adjust their approach to communicate, to relate, to react to the individual, to be better prepared and able. Because these are the substantial and specific barriers to good health care for people with intellectual disability. It's essential staff are aware of an increased pain threshold in many. Many carers highlight this as a key anxiety of theirs, due to the difficulty the patient has at communicating pain. It can have dreadful impact due to the patient's cognitive impairment or inability to explain or attract attention when the need arises. Many require support from others. A person's most important communication resource is their carer, to the point that many would find it significantly more distressing without that support and may even refuse hospital treatment unless they know their carer will be present. There is a common feeling among carers, fear of what would happen if they are not there. While Laurie was sleeping after one surgery, I went for a short walk to make a call to check on home. And when I returned, he was having a tonic-clonic seizure, and he was hanging out and over the side of the bed. His tongue was covering his small airway. I ran to him, calling for help. They were ages coming. I had warned them that his seizures occurred when sleeping. I prepared them. I delegated my care to them as I went for that short walk. Healthcare professionals have a key role to play and includes advocacy for the improved management of the quality of hospital experience for people of all ages with intellectual disability. You become the advocates in your work. From admittance to discharge, including timely access to services, effectively improving consultations, physical examinations, diagnosis and treatment, yet many doctors indicate that at this point in time they receive inadequate training to care for this group of people. We must do all that is necessary to avoid future failures, mismanagement, neglect, and discrimination. This is particularly problematic as those with complex challenges such as intellectual disability, autism, profound and multiple disabilities have greatly increased life expectancy, and a higher rate of dependency levels will see a greater number of vulnerable people with inadequate health and medical services. Systems will also be greatly challenged as well from the increase in the ageing population.